Hello, everybody. Hopefully you can all hear me. My name's Isabel. I am the communications lead at Central and South Genomics. Welcome to today's webinar, Bowel Cancer and Genomics, What Healthcare Professionals Need to Know. Just a little bit of housekeeping. So please keep your microphone on mute during the talks. We will be recording and sharing this session post-event to everybody that registered. And we're going to have a Q&A session at the end. So please just use the chat function to ask questions during the talk if you'd like to kind of note them down so you don't forget, or raise your hands during the Q&A to ask questions. So our agenda is nice and full for today. From about 1:05 in a few minutes' time, we'll give people some time to sort of join. We will start with Dr. Elizabeth Fuller, who works with us at Central and South Genomics. She's going to give an introduction to Lynch syndrome and how we manage that in a primary care setting. From 1:25 to 1:50, we've got Catherine Willis, who's going to talk about hereditary bowel cancers and genetic testing with a sort of genetic counselling and nursing perspective. From 1:50 until 2:15. Oh, got somebody not on mute. If you could just make sure you mute yourselves. Thank you very much. Until 2:15, we've got Professor David Church, who will be talking about future perspectives, predominantly the Lynch vaccine. And from 2:15 until 2:50, we're going to hear from Hilary Bates, who's going to give us the patient perspective and the sort of charity perspective from her role at Lynch Syndrome UK. And then we'll close that out with a Q&A at the end of the session. So, Izzy, have I got you on the call?
Yes, yeah, I'm here.
Okay, so I think if we give it just a couple more minutes for people to join, it's, lunchtime, so I know people will be kind of joining intermittently throughout. But I think in a couple of minutes' time, we'll be good to get started. Does anybody have any questions before we begin? Okay. So if we give it until 4 minutes past.
Yeah, that's fine. I'll just get my slides up ready if you...
Wonderful. Thank you very much.
Okay, I'll just make a start with the introductions. Thank you all for joining during your lunch break and for giving up the time to join us today. So my name's Izzy. I'm a GP. I'm currently working in the West Midlands, and as Isabel said, I also work for the Central and South Genomic Medicine Service Alliance in a non-clinical role. I'm going to do a brief outline of the session. So I'm going to start with a kind of introduction to the kind of science behind genes and how I might communicate that to a patient who maybe doesn't have a scientific background, touch a bit on Lynch syndrome, and then how that is different to managing in primary care as compared to just a patient that has bowel cancer that doesn't have an inherited predisposition syndrome. So when we think about DNA, we think about this double-stranded DNA helix. And if you unwind that, of course, we all know it's got the 4 base pairs that the order of these constitutes what our genes. So if I was explaining that to a patient, I might say it's a little bit kind of like the binary computer code that we all see these zeros and ones that mean not a lot to anyone on their own, but when they're all put together and they're all working, it's got a usable interface that we can all relate to. If we unwind our DNA and have a look at a longer stretch of it, of course, we have sections of genes, and these are our coding DNA, and they're held together by our non-coding DNA. So the genes themselves are like our instruction manual. They're telling us each step of the process to make the proteins that our body needs to generate a physical structure like an eye, an ear, whatever, or a chemical structure like a hormone that's important in chemical in how our bodies work and everything. So I might say to a patient, it's a little bit like an instruction manual or a recipe booklet. And it's there to generate our proteins, which are essentially our building blocks, the things our body needs to make up our bodies. The non-coding DNA sections in between are important. They have quite a structural role. Our genes all interact with each other. It's not as simple as just a recipe booklet, 1, 2, 3, 4, 5, 6. They interact in lots of different ways, and being held correctly in the right geographical place is really important for the body to work and process as it should do. So when we think about our bodies generating new cells, we need different things in our genes. So we need our proto-oncogenes, and these are our things that drive cell proliferation. So these might be activators and things. So when one gene finishes expressing, it triggers the next gene to start expressing. But we also need some breaks in this mechanism. We don't want to keep generating cells forever. So we have our tumor suppressor genes that stop the cells from proliferating. They might also have a role in mismatch repair. So when we generate new strands of DNA, our double-stranded helix actually splits in half, and we get a DNA polymerase enzyme that will bring new base pairs that match them and put them up to create two clonal pairs of DNA. Now, everyone makes the odd mistake here and there, and sometimes they can bring the odd nucleotide base in. What our mismatch repair genes do is they recognize that. They have systems in place to cleave out those abnormal nucleotide bases and to put the correct one in place. So that reduces the frequency of genetic errors. And they also stimulate apoptosis. So as our DNA starts to degrade, as it naturally will do with time, these tumor suppressor genes will tell the cell to sort of break itself down, and that's programmed cell death is called apoptosis. So what can go wrong in cancer? First of all, we can have a mutation in our proto-oncogenes, leaving them constantly switched on, constantly activating and driving that cell proliferation, so that we produce too many cells. We might have a mutation in our tumor suppressor genes, so they stop putting the brakes on and just continue to drive cell proliferation. They stop telling our cells to break themselves down. They stop this apoptosis. And because we're talking about Lynch syndrome today, they might also have a role in mismatch repair genes. So if they stop that kind of spell checker of the cell, we're going to end up with strands of DNA that have genetic mutations or variations in it. And that DNA might be less stable, might have even more sort of mutations in the tumor suppressor genes and the oncogenes. And therefore we get increased frequency of genetic errors. And these or any of these processes can all lead to cancer. Now, our patients, when we talk about cancer, cancer is essentially a genetic disease. A change in our genes is what leads to cancer. And a lot of patients come to us and they're very concerned because they have a relative with cancer and they hear genetic and they think, does that definitely mean that I'm going to get cancer or that I'm at some kind of increased risk? Well, the short answer to that is no. Only between 1 in 5 and 1 in 10 cancers will have a genetic predisposition. And the best way we can kind of reassure our patients and say yours definitely isn't genetic is actually by saying to them, can you go back to your relative that has a cancer and ask them to speak to their oncologist? The oncologist will do two different types of tests. One is the test of the actual tumour tissue itself. So they'll take a sample of the tumour, they'll run it through an analyzer, and they'll work out which genetic variant they think has actually caused the cancer in that particular patient's case. They can then take a sample of either blood or saliva, tissue from somewhere that's not inside that cancer cell, and they can look if that same variation is present, not just in the cancer cell, but in every cell in the body. And the crucial thing about this germline testing is that if it's present in every single cell in the body, there's a risk that it could also get transferred into the gametes when they're produced, and therefore there's a risk that that could be an inherited cancer. So what actually causes cancer? It's a mixture of genetics and the environment and how they interact to each other. We all have two copies of every gene. We inherit one from mum and we inherit one from dad. And cancer is actually thought to be a two-step process. So at some point, a carcinogen or something in the environment will take out one of our alleles, one of our genes, and will make it more prone to developing cancers. Now, we don't automatically develop a cancer at this stage because we have another working allele there that's going to prevent us and protect us from cancer. So years then go by and continued exposure to all these carcinogens will then cause a mutation or a variation in the other allele. And at that point, we've lost both of our tumor suppressor genes or proto-oncogenes have been turned into oncogenes, and that's the stage that cancer will start to develop. In a non-inherited cancer, these tend to happen over years, and this is why cancer tends to happen in older people. But in our inherited cancer predisposition syndromes, they've already inherited one of these alleles with a variation in it. So that first change will be the one that takes out their other gene, and therefore these cancers in patients with inherited cancer predisposition syndromes will generally occur earlier in life. So this brings us nicely on to Lynch syndrome. Lynch syndrome is an autosomal dominantly inherited condition. I'll explain that in a moment. It's an inherited cancer predisposition syndrome, and it's caused by faulty mismatch repair genes. Now, because it's present in every single cell in the body, these patients are at high risk at a young age of developing cancer, but also high risk of developing multiple different cancer types, with the highest risk being colorectal. Diagram shows quite nicely that a patient with Lynch syndrome has an 80% lifetime risk of developing colorectal cancer compared to someone that doesn't have Lynch syndrome, whose overall lifetime risk is only 5%. Endometrial cancer, we've got about 60%, ovarian 24%, and gastric cancer about 13%. So it's inherited when we have an inherited gene that's affected. If you have an affected gene, then you have Lynch syndrome. And when the gametes are produced, the parent that has Lynch syndrome will either pass down their unaffected gene or their affected gene to their gametes. They then meet a mate and they partner, and they will pass down their gametes to generate offspring. And there'll be one of 4 different combinations of these 2 people's genes. But essentially what will happen is that 50% of those combinations will have the affected genes and will have Lynch syndrome, and 50% will be completely unaffected. And the important thing to note is that these unaffected patients will not pass anything down to their children. They will have no chance of passing it on because they haven't inherited it themselves. And of course, the children that do have Lynch syndrome will then in turn have a 50% chance of passing it down to their offspring as well. Now, as a GP, when do I need to think about Lynch syndrome or an inherited cancer predisposition syndrome as a possibility? The Amsterdam criteria give quite a good sort of quick reference to think about things. So we say 3 cancers that are known to be associated with Lynch syndrome. So any in the family, the 3 cancers. They must span at least 2 generations, and at least 2 of those relatives must be first-degree relatives of each other. So that's either parents, siblings, or children. And 1 cancer has to be diagnosed young, so under the age of 50 as a general rule. If someone's coming to you and giving you this kind of family history, that should be raising real alarm bells, and we should be thinking about referring through to clinical genetics. So let's have a look at a case study. This is a completely fictional case study that demonstrates nicely how we would manage a patient with Lynch syndrome as compared to just having bowel cancer. So Marge Simpson is a 42-year-old female. She's had bowel cancer before. She's not on any medication. And I have a look through her consultant letters, and it confirms that she does in fact have Lynch syndrome. So her annual review is going to be slightly different to a patient that doesn't have Lynch syndrome. This Lynch syndrome quick guide is really, really useful. It's just a 1-page document that I like to download, have it on my desktop so I can flip back and refer back to it and make sure we're checking everything. The only thing just to raise with you is that the aspirin dose on this has now changed, and we'll come on to that when we talk about the CAP3 slide in a bit more detail later on. So her annual review is going to be broken down into 3 main sections. We've got her medical care and her screening. We need to also think, because it's inherited, about care for her family, and then think about surgical options and what might be appropriate for Marge. So the first thing we think about when we think about Lynch syndrome is H. pylori. And the reason we think about H. pylori is because if we treat it and we find it, we can reduce their gastric cancer rate by 50%. We said earlier that these patients have a 13% lifetime risk of gastric cancer because of their Lynch syndrome. So just for a simple course of antibiotics and PPI, that is a massive risk reduction for gastric cancer by doing this as a one-off test and treat. We also need to think about using aspirin. So aspirin is recommended by NICE to be taken for more than 2 years to reduce the risk of colorectal cancer in patients with Lynch syndrome. It's technically used off license, but there is good evidence to support its use, and it is recommended by NICE. So we should feel okay about prescribing this, provided there are no contraindications for other conditions. And the reason it's so important is because it's been demonstrated by the CAP2 study to give a 50% reduction in colorectal cancer rate after use for 5 years. But importantly, those protective effects continue for up to 10 years after stopping aspirin. Of course, not everyone can take aspirin if they're pregnant or if they're breastfeeding, sorry. If they think about their age, other risk factors, controlling their blood pressure and things like that. Things like that are really important to consider. So we mentioned earlier about the CAP3 trial, and so the original CAP2 trial was looking at really quite high doses of aspirin, looking at sort of 600 milligrams. And of course, that has a lot of side effects with GI bleeds, and a lot of people stopped taking it because it was intolerable to use. So the CAP3 trial, which has been released earlier this year, I think it was, looked at using lower doses of aspirin, and they found that they got exactly the same benefits using between 75 and 100 milligrams, or if the BMI was over 30, considering 150 milligrams. But of course, they got a lot less of the GI side effects, so it gave the same benefits for much less side effects and problems. They So the patient would take aspirin for 5 years, then have a 5-year break, and then continue that in 10-year cycles. And of course, looking at all the comorbidities and things that we need to consider. When thinking about using aspirin, patients need to be fully informed and make that decision with us. So there is a nice clinical decision aid that we can give to patients, which talks through the evidence and how we can use aspirin. This does mention 600 milligrams of aspirin per day. That's because it was written around the time of the CAP2 study, but we now recommend 75 to 100 milligrams or 150 milligrams if the BMI is over 30. So thinking about screening, we're going to give Marge a colonoscopy every 2 years, and we're going to start that from the age of 25. This is a relatively new thing, and it's important to remember that patients that were maybe diagnosed with Lynch syndrome many years ago may not be offered these colonoscopies every 2 years, although they are eligible for them. So this is where, as a GP, it's really important to talk to these patients and say, have you got into the National Bowel every 2 years? And of course, there are other national screening programs for breast and cervical cancer. Lynch syndrome doesn't actually increase the risk of breast cancer compared to the general population, but it is still really important that they attend their kind of national screening program. They wouldn't be offered any extra screening just because of their Lynch syndrome for these two cancers. So thinking about Marge's annual review again, we're also thinking about her family and how we can help them. So we know that Marge's first-degree relatives will have a 50% chance of having Lynch syndrome. So these would be her parents, her siblings, and her children. And they would be eligible for cascade testing because we know that their risk of having Lynch syndrome is 50%. Now, Marge's children are under the age of 18, so we're not actually going to offer them genetic screening until they reach the age of 18. In Lynch syndrome, this is because although cancers do occur young, they tend to occur in early adults rather than in children. And also, screening wouldn't start until the age of 25. We like to preserve patients' autonomy as best we can. And of course, once you know the result of a genetic test, that's not going to change. We can't unlearn that. So it's best for children to be able to delay their genetic screening from age 18. But it is important, if they did present with any kind of unusual symptoms or anything, if we know there's a history of Lynch syndrome, to have a low threshold for investigations of relatives at any age. Just as a note, if they did decide that they didn't want the genetic testing, they could still go for their 2 yearly colonoscopies. Now, when we think about Lynch syndrome, we know that they have an 80% lifetime risk of developing colorectal cancer. We know these patients that are first-degree relatives have a 50% chance of having inherited that gene. So if we work out the statistics from what we know that they roughly have about a 40% chance of developing cancer. Obviously, that would change depending on the genetic test result. So that's still massively higher than the background general population risk of about 5%, which is why they are eligible for colonoscopies even in the absence of genetic testing if they decide not to go ahead with that. Now, Marge might need to think about family planning as well. She's only 42, she could potentially still get pregnant, and she might want to think about contraception. Now, of course, hormonal contraception can carry an additional risk of cancers. Non-hormonal contraceptions are an option for her, but she might decide that she wants to use hormonal contraception for whatever reasons. And so it's our important as a job to be able to treat that and counsel her about that. So whenever I think about contraception, if I've anything that I'm not too sure about, I always look at the UK medical eligibility criteria. And this breaks down all medical conditions into categories. So category 1, as we know, there's no restriction, we can go ahead and use that, absolutely. Category 4, don't touch it at all. And then 2 and 3 sit somewhere in between. So as a general rule, I tend to shy away from using anything that's a category 3 or category 4 and generally go for anything, ideally a category 1, but a category 2 as long as the patient is happy to take on that additional risk. So looking at specifically at inherited cancers, the UK medical eligibility criteria talks specifically about breast cancer. So if there's a family history of breast cancer, any type of contraception is a UK MEC1 and fine to go ahead and use. However, it does say about carriers of gene mutations associated with breast cancer, such as BRCA1 or BRCA2, you notice that suddenly the hormonal contraception that contains the estrogen goes up to a UK MEC3, and we'd be looking at the progesterone-only contraceptives in these cases. Now, I mentioned earlier that Lynch syndrome doesn't actually carry an increased risk of breast cancer, but it does carry an increased risk of ovarian and endometrial cancer. And when we think about prescribing contraceptives, we also need to consider all of those types of cancer because we know that contraceptives are actually reduce the risk of ovarian cancer. I've put here the Mirena coil as a separate form of contraception, and that's because we use this when we're prescribing HRT to reduce the risk of endometrial cancer. And there is some studies looking into whether we could actually use this as an option to reduce the risk of endometrial cancer in Lynch syndrome. We can't use it at the moment, it's not been proven or anything like that, and we certainly wouldn't be prescribing contraceptives just for that risk reduction alone, but it might be something that the patient wants to think about if she does want to sort of preserve her fertility, but doesn't necessarily want to go ahead with like a full hysterectomy or anything like that, which we'll come on to shortly. So what do NICE say about prescribing hormonal contraceptives? First of all, it needs to be an informed decision. You need to have these conversations with women and let them make that decision as to what's important for them. We're considering the benefits, such as protection against ovarian cancer, but we're not prescribing just for the risk reduction in cancer alone. Now, Marge might be thinking about future pregnancies, in which case you might want to consider pre-implantation genetic testing. And you can refer through to the you can refer to the prenatal clinical genetics service for this. What essentially happens is that she will go through IVF. They will develop the embryos to the blastocyst stage, which is about the 8 to 10 stem cell stage, and they will take one of these cells and they will run it through a sequencer. And that sequencer will then tell them whether that embryo has Lynch syndrome or not, and they will choose to implant the embryos that don't have Lynch syndrome in preference to those that do. So you mentioned briefly about surgical options earlier. So a lot of patients with Lynch syndrome will have colectomies, and they will have that fairly early on, so about the age of 35 to 40. Once a woman has come to the end of her sort of reproductive life and has decided that her family is complete, she may want to consider gynecological surgery, so things like hysterectomy and oophorectomy. We talked about the Mirena coil may have a role in this. It's not something that we can recommend. At the moment, the recommendation is for full hysterectomy, but if she's still considering, it might be something that just reduces her risk short term while she's making that decision. And of course, once you do take out a lady's ovaries and uterus, you're going to put them instantly into a surgical menopause, which makes us think, can we actually prescribe HRT to a patient that has a genetic variant that results in a very high risk of cancer? Well, again, there's some guidance on this. Under the age of 50, it does have minimal additional cancer risk, but it has significant benefits in terms of maintaining bone density, reducing risk.
Oh, Izzy, I'm not sure if you can still hear me, but we've lost you, I believe. Might be worth perhaps turning off your camera and then trying again, or leaving the meeting and coming back in. Sorry, everybody. Let me try contacting Izzy directly. Apologies, everybody. It looks like Izzy's just jumped off. We'll just give it a minute or so for her to rejoin. Okay, so in the interest of time, I haven't heard back from Izzy as yet. Um, so what we might need to do, have I got Catherine on the call? Catherine
Yes, I
Willis.
am. Yeah, hi, I
Hi,
am here.
Catherine.
Yes.
Hello. Sorry
Hi.
to drop you in it really quickly.
That's all right.
Um, Next on the agenda is Catherine, who's going to talk about hereditary bowel cancers and genetic testing from a genetic counselling and nursing perspective. So I've got your slides up
Oh,
here.
lovely. Thank you.
Is that
I was just about to
showing?
show them, but that's perfect.
Yeah,
Yes, I can
perfect.
see them.
So
Do
if you just
do I have control of them, or do I need to ask you to move
I
them on?
think you can request access, but it's always a little bit patchy depending
Oh,
on sort of whether the trust allows it or not. So if you want to just let me know when you need the next slide, I can click through for you.
perfect. Thank you very much.
Wonderful. Thank you,
Um,
Catherine.
So, hello, everybody, and I'll just introduce myself to start with and then let you know what I'm going to talk about for the next 25 minutes. So, I was asked today to talk about hereditary bowel cancers and genetic testing of those, and to look at it really from the nursing and genetic counselling perspective. And I am a registered genetic counsellor, but I'm also a registered nurse, and I'm currently working as the Lynch lead in the Wessex region of the Central and South Genomic Medicine Service Alliance. And this post that I've been doing for just over 4 years is funded by the Wessex Cancer Alliance. Yeah, if you just move on to the next slide, thank you. So what I want to cover for the next 25 minutes is look very briefly at other inherited causes of bowel cancers and sort of put it in perspective in terms of the majority being non-inherited. We'll look a bit more closely at the genetics of Lynch syndrome, and some of that will overlap and reiterate what Izzy's just been talking about. And then the National Transformation Project and the testing pathway for Lynch syndrome in secondary care and onto tertiary care in the NHS now. And then something about the mainstreaming of genetic testing and the role of the clinical nurse specialist, particularly in the Wessex region. And then I've got a couple of case studies, which I hope will illustrate what I've covered in the slides to that point. Next slide, please. So if we look at the causes of colorectal cancers, overall, the vast majority will be what we call sporadic. So they just occur in that person, usually at a later age in their lives, can be because of environmental factors, or just because that when that DNA is copying and replicating, there's a mistake that's made, and that leads to a tumor in that person. A smaller proportion, so about 10 to 30%, are what we call familial. We don't find a specific genetic change for these. There's not one genetic reason, but there's a cluster of genes that are working together that confer a slightly greater risk in that family. So you might see a number of people that have been affected, but it isn't clearly genetic. And then there's Lynch syndrome, which on this slide they say about 5%, but actually on a later slide, I think it's really about 3.3% that people quote as the proportion of colorectal cancer that's caused by Lynch syndrome. And then there are rare conditions, which I will explain in a bit more detail in a moment. Next slide, please. And so this slide looks familiar because Izzy's used it as well. So I do find this when people are talking about Lynch syndrome in particular, we do use similar slides to each other. But if we just think again about that idea of the somatic genetic change. So in truth, all cancer is genetic, but the vast majority, as you saw from that pie chart that I showed you, are somatic or sporadic. So there will be a change in that DNA, but it will only be found in the tumor tissue, not in the blood of that person or the saliva. If the cancer in the person is a inherited type, then we can take a blood sample from them and we'll find it in every cell in their body, the gene change that's caused the cancer. And so we're seeing more and more somatic testing in cancer treatment these days. And so we think about tests such as BRAF and KRAS and POLE, which are done for colorectal cancers and endometrial cancers. And they often inform us about the treatment that person might need, but we wouldn't be worrying then about whether their relatives are at higher risk. For a genetic germline change, then we know that other people in the family are likely to be at risk of the same cancer developing. And that's when there's a change in the way that we manage that family. So the person themselves are at risk of developing another cancer, and it may affect the direct management of that current cancer, but we'll also be thinking about how we mitigate that risk in the relatives. Next slide, please. And so just to look briefly at those rarer colorectal cancer syndromes. So if you just press again, it will come up. So thank you. So I'll talk about Lynch syndrome in a lot more detail in a moment. But we also have some rarer inherited conditions. At the top of this slide, I've included the referral process for clinical genetics in the Wessex region. And we have very specific referral criteria, which will encompass all of these situations where a family might have one of these syndromes. And we're always interested in having referrals from people that meet the criteria of having a number of relatives affected or having polyps themselves at a young age. So there's a condition called FAP, familial adenomatous polyposis, and that's caused by a change in the APC gene. And it's a dominantly inherited condition, as is Lynch syndrome. But many of them, up to 30%, the person who's affected by FAP will have had the change in their gene starting with them. So actually the risk to other family members is less. So what we would do in that situation in clinical genetics is if we know the change in the gene that's caused it in the individual, then we're able to test their parents to see if it's been passed on or if it's actually started with them as a new mutation. This is rare. It's about 1 in 8,300 birth incidents. So it's a rare condition, and people will develop hundreds of colorectal polyps at a very early age. The next one I just wanted to mention to everybody is MUT-YH associated polyposis. And this increases the risk of developing polyps in the colon, rectum, and the duodenum. And it's caused by variants in the MYH gene. And where this differs from Lynch syndrome and FAP is it's inherited in an autosomal recessive way. And so if you think back to Izzy's slides where she showed that our genes come in pairs because we get one from mum and one from dad. And she had a very, very nice diagram of the way that it's inherited if it's autosomal dominant. Well, for an autosomal recessive condition, both the mother and the father will have to pass on a changed copy of their gene for that person to be affected. So the chance of passing it on is 1 in 4 for each child, rather than the risk for an autosomal dominant condition, which is 1 in 2. And I've just included on the slide a link to a very nice leaflet about MUT-YH associated polyposis that's from St Mark's. So if anyone wants to read a little bit more about it, then that will take you to it. And then just to mention as well, another condition that can cause inherited colorectal cancer is Peutz-Jeghers syndrome. Again, this is very, very rare, much rarer than FAP or MUT-YH, and it affects about 1 in 25,000 to up to 300,000 births, depending on the population that you're looking at. It is again autosomal dominant, and it's caused by a gene called STK11 gene. Next slide, please. So now I want to talk about Lynch in a bit more detail, having just briefly covered other inherited types of bowel cancers. So as Izzy has already mentioned, Lynch syndrome is an inherited cancer predisposition syndrome. So a person affected by this condition will have an increased chance of developing a number of different cancers. The incidence in the population is about 1 in 400 people, and those statistics come from UK Biobank, where population studies have shown that testing the genes that are implicated in Lynch syndrome, you'll find a change in one of those genes in 1 in 400 people. So it's a relatively common condition. And as I've said on the side about the proportion of people with inherited bowel cancers, about 3.3% of people with a colorectal cancer will actually have Lynch syndrome. But it's estimated that we only know about 5% of people with Lynch. So 95% of people that have Lynch syndrome don't know that they've got it. And just to mention, it was previously called HMPCC. So if that's in people's notes from way back, then that is now what we call Lynch syndrome. And it's just to make sure that people know that that's the same thing. So if you look at the graph on the side of this slide, this is a cumulative instance of colorectal cancers over someone's lifetime. And it shows that depending on the gene that is affected in Lynch, your risk of having a colorectal cancer is different. So the biggest risk comes from having a variant in MLH1 gene, and the lowest risk for a colorectal cancer is having a variant in PMS2. And that really drives what we do for people in terms of the screening that we offer. And it's another reason why it's very important to have identified the underlying genetic variant that causes Lynch syndrome in that family. Next slide, please. And so this just demonstrates again that there are a number of cancers that can be found in a family with Lynch syndrome. The main ones that we see are colorectal cancers in both men and women, and then endometrial cancers in women only, obviously. And the other ones that are a little bit rarer, ovarian cancer, prostate cancer, and urethral cancers. If you look at the risks in terms of the genes, then a colorectal cancer, there's a high risk if you've got a variant in MLH1 or MSH2, as shown on the slide on the graph on the previous slide. For endometrial cancers, MSH6 is also a very high risk for women. So it really, does help with that, giving advice and prognosis to people once we know that underlying genetic variant. Next slide, please. And so from the last two slides that I've shown you, you can see that the 4 genes that we're testing for Lynch syndrome are the mismatch repair genes. There is another gene that if we see a variant in that, we know that that can also cause Lynch, and that's called EpCAM, and that actually inactivates MSH2. So when we're doing the initial protein testing, which I'm going to describe in detail in a moment, if MSH2 is missing, we may on the genetic test see that it's actually an EpCAM variant. But the main genes that we look for in Lynch, and majority of patients will be those first 4 there. And as I said, it's autosomal dominant inheritance, which means there's a 50% risk of first degree relatives. The diagram at the bottom shows those mismatch proteins working on the genetic code. So you've got a mismatch there of a G and a T in the genetic code. It should normally be a G and a C. And those 2 proteins, MSH2 and MSH6, work together, and they will snip out that change on the genetic code and put in the right pairing, so it would be a GC. If you're somebody that's born with Lynch syndrome and you have a problem with your mismatch repair gene, you're much more likely to miss those changes in your genetic code when your cells are replicating, which is the reason why people with Lynch syndrome are more likely to get an early onset cancer, and they're more likely to develop one in their lifetime overall. What we do see is that MSH2 and MSH6 work together in what we call a dimer, and MLH1 and MSH2 work together in the same way. So we often see MLH1 and PMS2 work together in the same way. And so we often see on the initial testing that we do that it will be those pair that are missing together. Next slide, please. And so back in about 2016, there was a consensus meeting in London of a number of specialists who had noticed that the very poor identification rate for Lynch syndrome. So we obviously realised that we were missing so many people with it. And they sort of set about working out a way that we could improve this ascertainment of people that were unaware that they had this predisposition to cancer. And so in 2017, there were NICE guidelines brought in for colorectal cancers, which stated that anybody that presents with a diagnosis of a colorectal cancer should have testing of their tumour at that point of diagnosis, so ideally on the biopsy of the tumour itself, as soon as it's diagnosed. And that would either be done using something called immunohistochemistry, which looks at the proteins in the tumour and checks whether those mismatch repair proteins are present or not. Or you can use another type of testing called microsatellite instability analysis, which shows that it's likely to be a Lynch tumour if that is unstable in the tumour tissue. So the microsatellite length in the DNA, which are tiny, tiny little sequences all through our DNA, would be unstable if it was a Lynch tumour. In our region in Wessex, we do all of our testing using immunohistochemistry. So we're looking for missing protein in the tumour when we do that first initial test. And so this sort of formed the basis of the National Transformation Project for Lynch. And it became a recommended practice that all of these tumours should be tested. And then hopefully in the next few slides, I'll be able to demonstrate to you how a patient moves through that pathway and what that actually means to them. But if we just have a look at it whilst it's in front of us to show you what the next stage of it would be. So the first part is to look on the 4-panel test to see if MLH1, MSH2, MSH6 and PMS2 are present in that tumour tissue. If MLH1 is missing, whether it has PMS2 with it or not, you would go on and do a test specifically for colorectal cancers called BRAF, and then on to do a hypermethylation test of the promoter MLH1 if that BRAF test is normal. And then eventually that person would then go on to have their genetic test for Lynch syndrome. If we see that MSH2, MSH6 or PMS2 are missing, then you go straight on to do the genetic test in that person. And I just draw your attention to that sort of last stage there where the genetic testing takes place. So it says confirm Lynch syndrome by genetic testing of germline DNA. And historically, that testing has taken place in the clinical genetics service. But we've actually started to bring that into the secondary care service so that patients are seen in a much more timely manner. And I've got some statistics to demonstrate that in a moment. Next slide, please. So if you look at the testing pathway in detail, so everybody who presents with a diagnosis of colorectal cancer has that initial test done to see if they have the presence of all 4 of their mismatch repair proteins in the tumour test. So 15% of colorectal cancers will have a deficient mismatch repair protein. So 15% of them will then go on to potentially have some more testing done. So the first bit will be that 85% of those are missing their MSH1, PMS2, or MSH2 and MSH6 together. So the way those two work in pairs, that's the very, very common way that we see a loss in the protein. And then 15% will have a more unusual pattern of loss. So it might be that they have MSH1 and MSH6 missing, or they might have all 4 proteins missing in their tumour. Those people are much more likely to have Lynch syndrome. So if we see that on the initial testing, we have a much higher level of suspicion that it may be Lynch syndrome at that point. So thinking back to that pathway, if we see MSH1 and PMS2 missing, we'll go on to do the BRAF variant test and the MLH promoter methylation test. And those will actually rule out another 77% of that initial 15% of people. So we start to see the numbers drop off in that pathway. And eventually we get to the point where everybody that's presented with a colorectal cancer diagnosis, there will only be about 7% of them that actually need to have that germline test for Lynch syndrome. So it's a complicated pathway, but we start to get to the point where we're not offering genetic testing to lots of people. It would be about 7%. So just next slide, please. And the testing and referral criteria for this is very simple. So if you look at the left-hand side of this slide, there's a test that's called R210, which is for inherited mismatch repair deficiency. And the testing criteria is simply that somebody has presented with a colorectal cancer or an endometrial cancer, which is shown to be mismatch repair deficient. And then they've gone through that pathway. And if they don't have a BRAF mutation and they don't have MLH1 promoter methylation, or they have MSH2, MSH6 deficiency, then we go straight on to do that germline test. So that makes it very easy to bring that testing into the secondary care teams, because everybody is eligible once they've been through the pathway and got to that point of it. For those other rarer conditions that I mentioned at the beginning, then the clinical genetic services will see all of them. And so those people should be referred to clinical genetics, as they always have been, so that the more rare conditions can be tested for, rather than just Lynch syndrome. Next slide, please. And so the expected numbers that you're likely to see in the colorectal MDTs are actually quite small. So we start off, for example, in one of our very big MDTs, which is the University Hospital Dorset. There's 320 colorectal diagnoses per year. And so the number that will actually require a genetic test from that for Lynch syndrome is 22.4 people, so 7% of the diagnoses. And then the number of people that are likely to be diagnosed with Lynch syndrome after all of that testing and getting to the end of the pathway is about 10.5 people on average. So they aren't large numbers, and this is the work that the CNSs in Wessex have now picked up. Next slide, please. And so this type of testing, many of you will have heard of before, is called mainstream testing. So historically, genetic testing has taken place in tertiary care in clinical genetic services. And so we started the mainstream testing for Lynch syndrome in May of 2024 with the first clinics that were run. And since then, we've now done 73 germline tests in the mainstream setting. Of those, we've confirmed 21 people that have Lynch syndrome. We've had 51 negative tests, even though they've been all the way through the pathway and then had that germline test done. There's still many more that are negative for Lynch syndrome at that point. And we've had one patient that's had a variant of uncertain significance, which basically means that there is a change in one of their mismatch repair genes. But as things are at the moment, we're not certain of the significance of that change. So we wouldn't offer testing to their relatives based on that variant until we have more evidence to show that it is causing Lynch syndrome in that person. And so the really compelling evidence for the clinical nurse specialist to take this on is that the time from the cancer diagnosis to that germline result has reduced considerably in the time that we've introduced mainstream pathway. And so we now see a number of patients that have been through that testing pathway. So they've presented with their colorectal cancer and they've received their germline result within 63 days. The average is still 205 days, but I'm expecting that to reduce down significantly and be much more nearer to the minimum time, because we were actually pulling people out of the long waiting list to come into the mainstream pathway when we first set up those clinics. So they will have been on the clinical genetics waiting list, and then when we set up a mainstream clinic, we're able to see them in there, but they may already have been waiting for a number of months before we start those clinics. Comparing this to our traditional pathway, where people would have had their colorectal diagnosis, and then they would have had their treatment in the secondary care team, and then eventually they would have been referred to clinical genetics. And actually that's only if they were lucky to be picked up, because we know that before the national project started, only 25% of people were actually getting to that germline test. It was taking a year for them to go from their cancer diagnosis to their genetic result. I think the other thing that we've seen with the clinical nurse specialists in their roles within the secondary care teams is that patients are much, much less likely to be missed in this pathway, because the CNS really takes responsibility right from that first moment of diagnosis all the way through to the end of the pathway when they give that genetic result. And they're tracking those patients. And so we are now getting 100% uptake in the testing that's been recommended by those NICE guidelines. It's also worth just mentioning here that if you have a positive genetic test in a patient, then on average, 7 of their relatives will be tested for Lynch syndrome. So that's 7 more people, of which half are likely to have Lynch syndrome, giving the 50% probability of having inherited it. So that's 3.5 patients that can also have screening for this condition, and we can endeavour to pick up cancers at a much earlier age in those people. Next slide, please. And so I just wanted to try and demonstrate all that I've covered so far with a couple of cases that we've seen in these mainstream clinics. And so this first one was a patient that presented with a colorectal cancer at 89 years of age. And because of the universal testing for all colorectal cancers, it was picked up that she was missing her mismatch repair protein, MSH6. Interestingly, when we had looked into her history a bit more, it turns out that she had a previous endometrial cancer at the age of 50, which was actually in 1990. So that's a long time before this universal testing was stipulated. And that tumour wasn't tested for mismatch repair protein deficiency. She also had a family history which was quite indicative of a Lynch family. So her father had a bowel cancer at the age of 63. Her sister had an endometrial cancer at the age of 55. And her niece had also had an endometrial cancer. She couldn't remember what age she was at that time. So having gone through the pathway where we picked up that she had a deficient mismatch repair protein of MSH6, she went on to have her genetic test done by the clinical nurse specialist in that MDT, and it showed that she had a variant in her MSH6 gene. She didn't have any children herself, but she does have a sister. Obviously her brother's deceased. And her sister's got 2 daughters, and they've also got children themselves. So we're able to offer testing to her sister now to see if she also has that variant. And given that she had an endometrial cancer at a relatively young age, there's a high chance that she has got this variant. And then we'll be able to go on and offer those 2 daughters and potentially the grandchildren of her sister if either of the daughters are affected. We can also think about the daughter of her deceased brother, if she would like to have testing as well. So it's a nice demonstration really of how we were missing these people in 1990 for sure, and also even in recent years, and that this is really now picking up many more of the Lynch patients that would not be aware that they had that condition. Next slide, please. And so what happens after that diagnosis for that person is referred into clinical genetics, and they have genetic counselling around that diagnosis of Lynch syndrome. The clinical genetics department at the moment are the only people that can refer into the bowel screening programme for Lynch syndrome, so she'll be put onto the portal for that. We would give advice for aspirin and H. pylori, and then refer back to the GP to implement those treatments. There'll be a discussion about risk-reducing surgery, which Izzy touched on earlier as well, and around lifestyle advice, which is general advice really about reducing chance of cancer, and reproductive information for patients of reproductive age, and also organising the cascade testing of relatives, which I've just described on that pedigree. Next slide, please. And then I just wanted to show you about a negative genetic result. So this person presented with a colorectal cancer at the age of 54, and she was deficient with MLH1 and PMS2. So we went on to do the BRAF testing, which showed that there was no variant there, and then on to do promoter hypermethylation for MLH1, and that was negative as well. So she then went on to have her germline test. Her family history shown here on the pedigree, but when we did the genetic testing for this lady, she didn't have a variant in any of those mismatch repair genes. So what do we do now? Next slide, please. So there's a little bit more to the pathway in terms of the negative test. I put that on the left side of this slide. She would be referred into clinical genetics for us to review. So because this is quite a new pathway, we're still seeing everybody in clinical genetics at the moment, whether they have a negative Lynch result or a positive Lynch result. And so we would review all of the results to date. And I would think then about offering what we call somatic R210 testing. So we would look back at the tumour to see if we can find any changes in the Lynch genes in the tumour tissue rather than in blood. If we're able to find 2 changes, then we can reassure this family that it's a sporadic cancer in this lady, and there isn't any risk to other relatives. Often we don't find any changes at all on the somatic test or one, and then we're left with a question mark over whether this is a Lynch like family. And so we would then advise on screening recommendations for this lady and for other family members. She's got 4 children. They're not quite of the age that we would be offering colonoscopy yet, but we would review that as they reach the age of 25 and offer colonoscopy for unexplained deficient mismatch repair in this lady. Just to mention here that if somebody hasn't had a molecular diagnosis of Lynch syndrome, they can't be added to the Lynch portal. And so the colonoscopies for people that have chosen not to be tested genetically have to be arranged locally in the colorectal care teams. So just to mention that they won't be able to go onto that portal. And then I think I've just got one more slide. I'm aware that we're running out of time, and that's just to show that the National Transformation Project in England is starting to demonstrate a really increased pickup in Lynch patients, which is great to see. So in 2020, there were 545 patients picked up. We've now got 1,394 in 2024, and that's increasing year by year. I think that's all from me. So thank you very much for listening.
Thank you so much, Catherine. That was really, really informative. I know we're running slightly over, but I believe we've had Izzy rejoin the meeting. So David, if you can give us until, say, 2 o'clock, that work? And then we will be able to hop onto your slides next. Izzy, have I got you on?
Yeah, I'm back. Sorry about that. My computer just randomly decided to restart itself. If it had waited 5 more minutes, we wouldn't have had any problems. But I haven't got too many more slides left. Hopefully this was about where you lost me when I got onto menopause, whether we can prescribe HA to patients for genetic variants that result in very high risk of cancer.
That's right, yeah.
So so basically it depends on the age of the relative. So under the age of 50, the risks of cancer are they're minimal, but actually there are major benefits to prescribing HRT in terms of reducing the risk of osteoporosis and symptomatic relief of the menopause. And the British Gynecological Cancer Society and British Menopause Society have given joint guidance that recommends using estrogen-only HRT where clinically appropriate after a surgical menopause until the time that natural menopause would occur. Over the age of 50, we do have a slightly increased risk of breast cancer, so therefore we need to have a discussion with our patient about the risks and benefits and continuation over this age. Looking at these guidelines that we mentioned, again, it says that women need to have an informed decision. In cases where there is a high risk of gynecological cancer, we're advised to seek specialist advice. So these women with Lynch syndrome that maybe haven't had like surgical removal of the womb or the ovaries, but have gone into a natural menopause and don't want to have their womb or ovaries removed, then we would need to be seeking help from a specialist gynecologist there. If we are offering HRT, we would offer it until the natural menopause, and over the age of 50, we'd be continuing with caution. But as Lynch syndrome doesn't carry that additional breast cancer risk, our discussions with the patients about breast cancer would be the same for any patient that didn't have Lynch syndrome. In terms of the NICE guidelines, so they recommend, again, it being an informed decision. We're using the shortest duration at the lowest dose, and again, aiming to stop over the age of 50 years, considering alternatives where possible, particularly for things like osteoporosis, and when clinically appropriate, estrogen only. So those were all my questions. I don't know if anyone had any questions or if we want to carry on to David's and take questions at the end.
Yeah, we'll carry on to David's now and then take questions at the end because we've ring-fenced a bit of time for that. So David, if you're happy to share directly, that would be wonderful.
Yeah, absolutely. Give me 2 ticks and we should be able to see them now, I hope.
Yep, that's there. Thanks so much, David.
Fantastic. So thanks for the invitation to speak. And I'm just going to update everyone on this program we have in Oxford Lynch Vax, which is working towards vaccination for Lynch syndrome, which you just heard beautifully about from Izzy and Catherine, of course. So my disclosures. Briefly, because you've heard this already, Lynch syndrome is not rare. It's actually quite common. 1 in 300 people. A lot of people actually think it's more common than that, actually, but that means there's 175,000 people in the UK with this. As you've heard very nicely, massive increase in cancer risk for these people. And although we can reduce that with regular aspirin and surveillance colonoscopies every 2 years, there is still a huge unmet need for cancer prevention in this population. Recognising that, as Catherine's just highlighted, the transformation project has made good inroads in this in terms of diagnosing, and you see the uptick in diagnoses by year here from the work that Catherine and others across the country have done. And that's really set the stage for concerted efforts now to try and reduce the cancer risk for this important population. So if we go back to the biology, just to remind ourselves of what's happening at the molecular level for people with Lynch syndrome and why they get cancer, normally our copying of our DNA is incredibly accurate because we've got these copying machinery polymerases here, which have a little bit called an exonuclease domain, which double checks that the correct DNA has been inserted across the template strand. And then after that, there's further surveillance of newly synthesized DNA, newly replicated DNA by something called the mismatch repair system. And collectively, you start off with an error rate. So one of the DNA bases, letters, is copied erroneously in about 1 in a million bases by the replicative polymerases. That was reduced to 1 in 100 million by the polymerase proofreading, and then the mismatch repair drops that right down to 1 in 3 billion. So that's only one uncorrected error every time our DNA is copied, which obviously is done all the time in all the cells of our body, or most of the cells of our body. We're focusing here on the mismatch repair system, which is what's at fault in Lynch syndrome, as you heard very nicely in the previous talks. And of course, if the mismatch repair system is non-functional because you're born with one faulty copy and then you lose the backup copy in your cells in adult life, then that uncorrected error rate goes from that 1 in 3 billion up to a 1 in 100 million. So that gives you error-prone copying of DNA. And as a consequence of further errors in the DNA, further mutations, you get mutations in tumor suppressor genes and oncogenes, which collectively lead to cancer. And that's why people with Lynch syndrome have such an increased risk of cancer. So there you see it in the schematic. And one of the consequences of that, because the DNA copying in these precancers and cancers of people with Lynch syndrome is error prone, you get a very high number of mutations in the cancers caused by Lynch syndrome and mismatch repair deficiency in general. So here we're looking at a number of cancer types analysed about 12 years ago in this landmark study. Some cancers here have a very low number of mutations. Other cancers here on the right of the panel have a very high number of mutations. In the case of melanoma and lung cancers, this is because they have exogenous mutagens, so ultraviolet radiation for melanoma, tobacco smoke for lung cancer, of course. But then in the middle here, you see these common cancers like those of the colorectum, endometrial cancer here, cancer of the uterus, where you've got a subset of relatively modestly mutated cancers here, but then a subgroup within those that have a much higher burden of mutations, which is caused by loss of mismatch repair, including by Lynch syndrome. So these cancers are hyper-mutated, as we say. And the mutations don't just occur at random throughout the genome. They occur at increased rate everywhere, but there's particular propensity, particular risk for mutations and uncorrected errors at repetitive DNA regions, which we call microsatellites. This is where you've got one letter, one DNA base repeated, or two bases just repeated in this repetitive sequence here. And the copying machinery is very prone to slip at these regions. Normally that's recognised and corrected by the mismatch repair system, but if it's not, then you get this uncorrected slippage and you get this phenomenon known as microsatellite instability. So you'll often hear about mismatch repair deficiency and microsatellite instability interchangeably, and that's what they're referring to. So you get this unrepaired error, a slippage event which can lead to an insertion or a deletion mutation, as we call it, to use the terminology. And that's important because if that occurs in the 1% of our DNA which encodes protein, it can change the spelling for the protein sequence. So every three nucleotides codes a single amino acid. So amino acids, the building blocks of protein, of course. And normally those three DNA letters spell one amino acid, and that's regulated very tightly. So you have a specific number of amino acids, and then it stops. But in the context of uncorrected frameshift mutation, you can get this novel sequence of amino acids in the protein, what we call a novel open reading frame, and a frameshift peptide. And that's important because these peptides here are not normally present in the human proteome, and so the immune system can recognize them as being non-self. A bit like with the virus or a bacterium, the immune system can recognize the little proteins, the protein peptides, chopped up fragments of proteins, as not being from the human and target them. So these things are different from the normal proteins, peptides in the body, so the immune system can go after them. And you see the consequences of that here in this image of a colorectal cancer. The brown dots here are cytotoxic T cells, so these are cancer-killing T cells, immune cells. And what we're looking at here is a common or garden mismatch repair proficient microsatellite stable colon cancer, where you see a very low number of T cells in the tumour. Contrast that here with the mismatch repair deficient tumour, which is absolutely peppered with cancer-killing T cells. And this is why in early stage disease, stage 2 disease, colon cancers with mismatch repair deficiency, including those caused by Lynch syndrome, have a better prognosis, and we use that in the clinic. So obviously that begs the question in turn, well, if these cancers are so immunogenic, if they're recognised by the immune system, why aren't they killed by the immune system? Why do they become cancers at all? And the reason is because these cancers upregulate mechanisms by which they can evade immune destruction. And one of them that's really important is upregulation of what we call immune checkpoints. Here's one which is famous for its targeting, PD-1. And what you see here, if you compare the mismatch of proficient and deficient cancer, you see upregulation of this immune escape mechanism, immunosuppressive mechanism of PD-1 upregulation, which serves as an invisibility cloak. And of course, that's clinically relevant because we can target those alterations, that upregulation with drugs, antibodies that target these proteins, which have led to deep and prolonged responses in the clinic. So for patients with metastatic mismatch repair deficient colorectal cancer, before the advent of these treatments, people would typically die from their disease within 6 months. What we see now is patients who are alive and free from disease 2 years plus out from therapy because they've been cured by immune checkpoint blockade. So that is absolutely fantastic and a real game changer. But of course, the problem with that is that not all patients who are treated with checkpoint blockade benefit from these therapies. They're expensive and they are associated with long-term endocrine risk. So patients typically have defects in their thyroid or adrenals, and long-term adrenal insufficiency is not completely benign, of course. There are appreciable risks with that. And so if we're thinking about prevention, immune checkpoint blockade is probably not the modality of choice, of course. We do think about prevention that we've known for many, many years, 2,500 years plus, actually, that's obviously preferable to trying to cure cancer after it has occurred. And we're quite well placed to think about prevention for Lynch syndrome because we know a lot about the biology. And the reason we know a lot about the biology is people with Lynch syndrome get colonic polyps, which lead to colon cancer. So a big increased risk in that. But of course, you can sample cancers and polyps from the colon. And through colleagues in Oxford and globally who've done a lot of work on the biology of Lynch pre-cancer, we know many of the steps that we think occur in the transition from normal colon to cancer in these people. First alteration is that loss of mismatch repair in the intestinal stem cell compartment in the colon, and so you have this little group of cells here that have lost mismatch repair. Then they get that error-prone DNA replication, and the propensity for these frameshift mutations, which cause frameshift peptides, and these can cause a T cell response, so they can induce that immune response, recognizing those peptides as being not me, and that starts to target the cancer or the developing pre-cancer, I should say. But of course, that's counterbalanced by mechanisms of immune evasion, like PD-1 upregulation, like infiltration of immunosuppressive T cells, as you see here. And if that dynamic is skewed towards tumour progression, with immune evasion being an ascendant, then you get development of a cancer, you get other mechanisms of immune escape, and so the patient goes on, or the Lynch carrier goes on and develops a cancer. But what we think we can do with a vaccine, or the rationale underpinning vaccination, is we can identify these frameshift peptides if they're recurrent, use a vaccine to train the immune system against them, so it's able to better respond against them, and in so doing boost the anti-tumor immune response and push back that push back that precancerous polyp and eliminate it before it has a chance to develop those mechanisms of immune escape and become a cancer. So that's the overarching rationale behind vaccination in this context. And we're not the only people with this interest and with this thinking. And this is a study that was published in Nature Medicine earlier this year by an Italian-Swiss company, Newscom, who have a vaccine against 209 frameshift mutations. And what they showed in this initial study, with references down here, is that the vaccine elicited an immune response, as you see here, with immune response against these peptides, although that was somewhat diminished 1 year after vaccination. But what it's doing here is providing proof of principle that you can vaccinate and train the immune system against these recurrent frameshift mutations caused by the loss of mismatch repair in Lynch syndrome. So we launched this LynchVax project in 3 years ago here in Oxford, and I've led it since its inception. It's a multidisciplinary group, including cancer scientists, informaticians, trialists, immunologists, and really importantly, people with lived experience of Lynch syndrome who've been with us from the start. And I think we're going to hear from Hilary in just a moment about her journey and her experiences. But this has been hugely valuable for us in the project, because we've been able to take on board what people who are seeking to help really need from a vaccine, and what's acceptable in terms of a clinical trial. So just a note that we're hugely grateful to our PPI collaborators for their input. We started by leveraging a fantastic genomic resource that we have in the UK through the 100,000 Genomes project run by Genomics England. In this project, we've got analysis of the whole genome, so all the DNA of 2,000 colorectal cancers, nearly 700 endometrial cancers. We published this study a couple of years ago in Nature. This study of the endometrial cancers we're just about to submit for publication. And what we did is we looked at the subset of these cancers with mismatch repair deficiency. So what we're looking at here is the hypermutation, the elevated mutation burden in these tumours compared to the others. And this hot pink thing here is the genomic scar, mutational scar of mismatch repair deficiency. We then asked the question, if these frameshift mutations are recurrent, how recurrent are they? And what we find is that they are very recurrent. So the most commonest of them in colorectal cancer occurs in 85% of mismatch repair deficient colon cancers, slightly lower frequency in endometrial cancers. But what we can do here, highlighted in orange, is to combine the two and say which of these frameshift mutations are present in more than a quarter of the colorectal cancers and the endometrial cancers, i.e. they could serve as vaccine targets for both cancer types and maybe even others as well. As you can see here, there's a good number. In fact, there's 29 shared in these. We've subsequently extended this to other cancer types with mismatch repair deficiency. So there's a good number of targets in the cancers. But of course, the cancers we know have these mechanisms of immune escape. So what we really want to know is, are these targets there in pre-cancers? And so we were able to leverage some resource that we have here in Oxford locally. And this is thanks to people with Lynch syndrome who've agreed to donate their samples when they have surveillance colonoscopies for research. We could do genome sequencing on these very early pre-cancers and confirm that of those 29 frameshift mutations in the polyps that have the mismatch repair deficiency, these Lynch polyps, between 10 and 17 of those 29 recurrent targets are already there. And bear in mind, these polyps are only typically 5 millimeters across, very, very early stage in their development, and the vaccine targets are already there, which is very encouraging. So we got some academic funding to take this project forward from Cancer Research UK, but we were very clear-eyed from the start of the project that as academics, we don't have the capacity, the wherewithal to deliver a vaccine as quickly as some of our partners in industry do. And so we actively sought collaboration with industry, and in July 2024, we signed a large agreement with the US company Moderna, under which we shared the data that I've just shown you. And Moderna were able to use our data to update and refine their vaccine design. They had a pre-existing vaccine design based on their data. They were able to improve that in very short order, actually. And they funded us to continue the work that we've been doing on more samples, which we've done. And I'd be delighted to share at a future meeting. In August last year, we expanded our collaboration to do further work studying the immune response against these vaccine targets that we have, and a better understanding of the biology of these Lynch syndrome associated precancers. And that's ongoing work we're doing here in Oxford, which is leading some very interesting results. In parallel with that, of course, I'm a clinician, I'm a medical oncologist, and the overarching motivation that we have, of course, is to get a vaccine into the clinic for the benefit of people with Lynch syndrome. And I'm delighted to report that in November last year, we signed a clinical trial agreement with Moderna to do their vaccine, the study of their vaccine, which will be opening in Oxford, as I show you here. So this is a Oxford University sponsored study funded by Moderna, comprising a first-in-human dose escalation phase, what we call Part 1, and then an expansion phase in Part 2. The dose escalation is very standard, schema here. So we start with a low dose of the vaccine to make sure it's safe and well tolerated, and then we go up and we're doing a whole load of correlative work in terms of the immune response against the vaccine in the people who participate in this study. The primary endpoint of this will be safety and tolerability, and we'll define 2 doses to take forward to the expansion phase, in which we'll do further confirmation that the vaccine is safe and well tolerated, of course, but it will also crucially be looking for some evidence of biological signal, which will be very interesting work. Again, heavy translational element of this study, so it's going to be very, very interesting, both from a clinical and a scientific standpoint, of course. Doing the first in human in Oxford, and then expanding for the second phase to Newcastle and St Mark's, and probably also a couple of other sites which we're just in discussion with at the moment. So that's all very exciting. We've got a great team. I lead the study, but really couldn't do without all these other people as well, both from oncology, gastro, pathology, immunology, collaborated at recruiting sites, and really importantly, just to reiterate our PPI representatives who've been hugely helpful. You know, when we think about the trial design, they were able to say, yes, this is something we would be happy with, or you might want to think about this, review the patient-facing material, etc. Huge thanks to all of the group actually there. We've had some engagement and some media attention, which is really nice. It's a real privilege to be able to share progress of the trial towards opening at the Lynch Syndrome UK annual meeting, which I've done the last 3 years. Spoken many times to Lynch carriers at patient events, which again is hugely rewarding and motivating. That really gives us the motivation to keep working on the project and really try and get it into the clinic as quickly as possible, of course. So just to sum up, I hope I've shown you that vaccination is a rational strategy to what we call intercept or prevent Lynch precancers from becoming cancers, we hope. Our Oxford industry collaborations accelerated our progress towards a clinical trial. We're hoping to open next month, actually, so things are moving very fast now, which is really exciting. And I'm really keen and enthusiastic about updating you on progress of the study at a future meeting, of course. Huge number of people working on the project in Oxford, at Moderna, and elsewhere, of course. That's a summary of where we are and where we're going. We do have a mailing list. If anyone's interested, please do email Sarah to sign up, and I'll stop there. And I think we're going to take questions at the end, aren't we, Isabel? So I'll stop sharing there.
Yes, thank you so much, David. We will be taking questions at the end, and thank you for your talk. Really interesting to see the progress from last time I heard about it. So yeah, really grateful to have you here today. Have I got Hilary? I think I can see you on the screen. Hilary? Sorry, everybody. I'm just having a look to see if we've got Hilary. I think she was here throughout, but it may be that we've had another IT issue, which seemed to be plaguing us today. David, just while we wait, there's a question. I can see you've responded to that in the chat.
Hilary was definitely here, wasn't she?
She was, yeah. It may be that we've had another IT issue, as Izzy suffered one earlier. Phil, can see your hands up.
Yeah, sorry, I just wanted to ask a question of David if Hilary's not going to be.
Yeah, absolutely. If you ask David, I'll try in the background. Thank you.
Thank you, David. I just wanted to, I think I have 2 questions. Number one is, Do you see vaccines eventually replacing or complementing the current strategies like aspirin and the colonoscopies, or are they likely to remain that additional layer of prevention?
Yeah. I think for now, complementing, Phil.
Okay.
Yeah.
Thank you. And then I suppose then my next question is then how, if they are complementing, how are we going to ensure equitable access, given that there is that current variation in diagnosis and follow-up?
Yeah. It's always a challenge, and I think the barriers towards vaccine uptake will be the same as we see for, sorry about the background noise, will be the same as we see for for other interventions, preventatives like aspirin, and so collectively we just need to work to address that really. And I think that sharing background and informing people about vaccination and what it does and what it doesn't do is super important here. So there's a really important piece for education for all of us, I think, collectively. So yeah, good point.
Thank you.
While we wait for Hilary, there are a couple of other questions in the chat. So Belinda, I can see that you asked, in the new digitized genetic testing directory, assume our number has changed, but is the grouping of tests the same? Would you be able to clarify exactly what you meant by that? When you say grouping of tests, do we mean in terms of the broad areas, i.e. kind of somatic, hemonc, rare disease?
Yes, sorry. It's just I'm aware that, normally these things can be grouped or they can be picked individually when you're requesting testing. And we were trying to make sure that MDTs got into the habit of thinking about the whole test for Lynch, not just a specific thing. And so we're asking people to think of it in terms of, the R numbers. But of course, obviously with the digital, I can't say that word. I obviously haven't had enough coffee today. But with the new directory being digitized and the numbers changing, it was just, is there a straight correlation and swap over to what was there and is there now, but we'll just have a different letter in front of it? Or were the grouping of testing slightly changing? That was where my question was coming from. Does that make sense?
Yeah, no, it does. I think that would be one to go back to the informatics team at NHS England on the specifics of that. We have had a little bit of information come through. I'll hand over to Phil in a second, who will be able to answer too. But one thing to note is that the digitalized version, the intention is to have that quite keyword searchable. So as opposed to just being able to search by our number on the spreadsheet, that you will be able to put symptoms and sort of different conditions in there, and that will pull through the relevant tests. But obviously it's early stages yet, with the go live not till October this year.
No, I understood that. I just thought I'd take the opportunity was a bit more specialist to ask the question.
Absolutely. Do you have the beta testing website available? Because there is a way to submit feedback on that. So I can send you the link to that if you don't have it, Belinda.
Oh, that'd be great. Thank you very much.
No problem. And Phil, I think you might be able to help on this one too.
Yeah, no, I was just going to say that in the new test directory, when it is live, they will be grouped, and when you put in for Lynch syndrome, it will have the different tests that are all available. So you can either look for the package, or you can just look for the test. And I'm hoping that I've just put the doesn't come up properly, it's come out that way. The test directory, the new test directory, you can have a look on that link. I've just popped it in there, and they are very keen for feedback.
Yeah, thank you, Phil. And just to note on that the intention is not for people to be utilising that as the test directory right now. It's the sort of testing phase.
No, I understand it. But you can go on. I understood that you could go on and just play, if for want of a better description, and then for people to get used to doing that while it's in the beta phase.
Yes,
absolutely. It's really helpful. Thank you both. I'm just searching through for some more questions. Hilary, I can see that you're back in.
Hello. Yes, I am. Sorry about that. I think it was the network here. It just decided to drop me at the exact wrong moment.
It's the day of IT issues, so don't worry about that at all. Thank you very much. It might be easier if you turn your camera off, Hilary. Sometimes that helps with my connection. Okay. Just if you're struggling. But thank you very much for rejoining. We've got Hilary Bates here, who's going to give us the patient perspective on Lynch syndrome. And also she works with Lynch Syndrome UK as a trustee. So I will hand over to you now, Hilary. Thank you very much.
Thank you. Hello to everybody. I was diagnosed with Lynch in 2008 at the age of 50, having had ovarian and endometrial cancer 2 years previously. I am what might be termed an expert patient, but also my background is in the pharmaceutical industry, and I was an information scientist in pharma for nearly 30 years. I'm now retired. So when I was first diagnosed with ovarian cancer, the endometrial cancer was unsuspected at the time, but picked up by pathology. And when I was going through chemotherapy, I was reading around the subject and discovered some writing about Lynch syndrome. And I said to my oncologist, should I be tested? This also followed on my aunt, who was a GP, having rung me up to say, did I know about all the family history? I didn't know all of it, but I certainly knew my mother's family history, because by then she had had endometrial cancer at the age of 46, ovarian cancer at the age of 58, and bowel cancer at least twice at 65 and 78. She probably had a third bout, but by then she'd descended into dementia and couldn't give a proper history. She also declined to be tested, but she obviously was the one who had Lynch. So I think, being educated and certainly having an education in a relevant area helped me get seen and get diagnosed perhaps faster than other people might have done. But even then, it was over 2 years between first raising the subject with my oncologist and actually getting test results, not least because the testing itself took 18 months. I find the topic very, very interesting, and I'm absolutely fascinated to see David's research and the vaccine work going on, and looking forward to hearing more about that. I participated in the CAP3 trial, and was actually on the lowest dose of aspirin, which I'm still on. And I've also participated in a fit for colonoscopy trial, which is based out of St. Mark's. But since going on to the bowel cancer screening program, I'm no longer directly under St. Mark's, so I'm not sure exactly how long that will continue. Anyway, I find it all interesting. I hope you do too, and I'd be happy to answer any questions.
Thank you so much, Hilary, for giving us that perspective. So we will now move on to questions. We do also have a feedback form, so please do send through any feedback that you've got for us. We like to see what we can cover for future topics and just to see and measure how we're doing. But does anybody have any questions? If so, please do raise your hand or pop them into the chat. Can't see any hands or any questions. So if nobody has anything further, we can close down earlier than planned. But thanks to everybody for joining today. Thanks to all of our speakers for sharing with us. It's been really fascinating to hear what's happening in this space. We have recorded this session and we will be circulating this with everybody who registered. It will also go on to all of our kind of standards for platforms and out through our normal mechanisms. And we do run monthly webinars on a range of different topics which are relevant to genomics. So please do sign up to our mailing list. We did ask you at the point of registration, so you'll be added if you said yes to that, but if not, have another think. And we will be in touch with you shortly, probably this week, to send through the recording and any further links that are of relevance. We'll also share the slides. So thank you to everybody for joining. Have a lovely rest of your day and we'll see you soon.